It's one thing, like, otherwise they can't hear you. Brilliant. Can everyone hear and see me? Or Dr. Waleed? Everyone hearing that is remote?
I think so, yeah.
Brilliant. Brilliant. So without further ado, I'm going to pass over to Dr. Mohammed to talk about Optune and lung cancer.
Perfect. Thank you, Lily. If I want to shift slides,
Just keep pushing that way. It's a bit weird. Just click on that one, maybe.
wait, this one.
And then the microphone is you and not this one.
Thank you. Okay, thanks, Lily. Good afternoon, everyone. My name is Waleed Mohammed. I'm one of the consultant clinical oncologists at Charing Cross Hospital. I specialize in neuro-oncology, and I share the practice with Matt Williams, Wakar Salim, and Seema Dadania. But I also spend 50% of my time specializing in lung oncology, and I do that with Seema Dadania as well. So this is a slight tangent from what you guys have mostly experienced today, because I'm hopefully talking about Optune and its benefit in thoracic cancers. Now, just to be clear, thoracic cancers encompass all of lung cancer, thymomas, and mesotheliomas. Mesotheliomas are a type of cancer that affect the lining of the lungs, the heart, or the abdominal cavity. So they all come under thoracic cancers. I'll be focusing specifically on non-small cell lung cancers and mesotheliomas. I'll tell you a bit about the cancer demographic in the lung population, the different types of cancers and their treatments, the current standard of care, and then I'll introduce the trials and how Optune is slowly garnering interest and momentum in this subspecialty as well, which I hope you'll find interesting, and then questions at the end. So lung cancer, as I'm sure you'll appreciate, is a very different disease and population compared to brain tumors. So while GBM affects about 3,000 patients a year in the UK, lung cancer affects closer to 50,000 patients. The split between men and women is roughly 50-50, although the prevalence patterns are increasing in women and dropping off in men, and this reflects sort of historical smoking patterns. It's the second most common cancer after breast cancer. So although more women are diagnosed with breast cancer, more women actually die of lung cancer. And mesothelioma, which is one of the subtypes of thoracic cancers, affect about 2,500 people in the UK per year. By far, the commonest causal link is active smoking. There's a 70% association, but that leaves 30% with passive smoking, industrial exposure to gas, chemicals, etc., air pollution. And with mesothelioma, there's a particular predilection for exposure to asbestos, such that the government compensates you if that's if industrial exposure is a reason for the mesothelioma. Unfortunately, most cancers, even until now, and this is both in the UK and globally, most lung cancers present at stage 4. That's 40 to 60% of cancers. It's not difficult to explain why. The insidious and pernicious onset of symptoms such as cough and shortness of breath, especially after a few years of COVID, means that by the time most people present, they're already in the advanced or incurable setting. It's very rarely that people actually present with something like chest pain or coughing up of blood, which is what brings them into hospital much more acutely. In terms of separating out lung cancers, there's different ways to categorize them. So you've got primary lung cancers that start off in the lungs versus secondary cancers that end up in the lungs from, say, the breast, the prostate, the bowel. So I'm limiting myself to primary lung cancers today. Within primary lung cancers, the vast majority, about 85% of cancers, are non-small cell cancers. There are small cell cancers, neuroendocrine tumors, which are not focusing on. We're looking at the non-small cell cancers and the much smaller subset of mesothelioma cancers. Again, we're talking about advanced or metastatic lung cancers rather than the early or the curable case. And in the advanced setting, the standard of care at the moment is chemotherapy, immunotherapy, and personalized tyrosine kinase inhibitors, which are tablet medications. Surgery and radiotherapy, which are the curative treatments for the early cancers, I'm not going to focus on. In fact, there's been a bit of a renaissance in the management of early lung cancers in the last 5 years. Certainly in the 5 years that I've been practicing as a consultant, the landscape for lung cancer is probably unfamiliar. It's incomparable to what it was, say, 10 years ago. Even, for example, if you focus on the early lung cancers, In the last 4 to 6 weeks, we've had authorization for perioperative pembrolizumab, adjuvant alectinib. In the last 6 weeks, this has happened. And in the last few months, in the last 5 years, the landscape has really, really changed. Added to that, we've now got lung cancer screening. So historically, we've always screened for breast cancer, bowel cancer, and cervical cancer. For the first time ever, we've now got lung cancer screening, and London is steamrolling all full steam ahead with recruitment. So 55 to 75-year-old, if you've had a smoking history, you're invited to a low dose CT scan every couple of years. The idea behind this is that you want to pull people from stage 3 and stage 4s into the curative stage 1 and stage 2. And that's where innovative treatments like SABR or stereotactic ablative body radiotherapy associated with the MR linear accelerators, this is all taking off. All of this is in the scope of the early stage cancers. Unfortunately, when it comes to the advanced cancers, much to be desired. Okay? The current standard of care is either a combination of chemotherapy, immunotherapy, or oral tyrosine kinase inhibitors, which are a tablet treatment. Chemotherapy and immunotherapy are delivered in the outpatient setting as a 4 to 6 hour infusion every 3 weeks, 6 weeks, 12 weeks. And you have a course of treatment that might last up to 2 years, bearing in mind side effects, disease progression, failure of treatment, etc. And precisely which treatment you go through, whether it's chemotherapy, immunotherapy, or TKI, depends on things like your fitness, your immunohistochemistry, your next generation sequencing profile, so personalized to you. And we know that chemotherapy has been around since World War II. Immunotherapy has been around for the last 20 years. TKI treatment has been around for the last 10 to 15 years. So things do need to change in this advanced setting, which is where Optune comes in. I'm not going to spend much time on this slide because my colleagues have spoken extensively about this. It's just to highlight that it's not just brain cancer and lung cancer that Optune is finding a role in. Trials are undergoing in sort of pancreas and ovarian cancers as well. So hopefully there'll be further updates on those in future study days. This will look familiar but different to most of you in this room. So the transducer arrays are larger than what you use for GBM on the scalp, but there are still 4 of them. So 2 go onto the front, and the other 2 either go under the axilla or armpit or onto the back. I don't know if you can see on that reflection in that mirror. There are 2 on the back over there. And they're designed to be worn 18 hours or more a day, as Matt's talking about earlier on. Obvious differences between Optune, wearing Optune in lung versus brain cancers is that, number 1, you don't have to shave your hair. Number 2, the pads are under your clothing, so they're more discreet. And number 3, the weakness that affects a lot of our patients with GBM and impacts them being able to carry the portable batteries is probably not an issue so much in the lung cancer. So if it's tolerated in our GBM patients, it's much more likely to be tolerated in the lung cancer patients as well. We're moving on to the trial. So the equivalent of the F14 trial in GBM is the LUNAR-1 trial in lung cancer. So this was looking at non-small cell lung cancer. It was a phase 3 trial, 276 patients. The trial completed in 2021. Since then, the standard of care for first-line lung cancer treatment has changed, and I'll go into that. But essentially, if patients had progressed on their first-line chemotherapy, the next line options, which were second-line chemotherapy or immunotherapy, adding in Optune to those or not was the question. Is there any benefit? So this is what the tree looked like, essentially. So adult patients with non-small cell lung cancer who progressed after their first-line treatment, they're going on to second-line treatment. Should they get Optune or shouldn't they? And then you follow them up. And the important thing to say is, number 1, there was a clinical and a statistically significant extension of overall survival. Now, it averaged to about 3.3 months, but if you separated that into the patients who went on to second-line chemotherapy as opposed to second-line immunotherapy, the patients who'd received the immunotherapy actually appeared to have a better extension of their median overall survival. Why that is difficult to say. Is it a cause? Is it an effect? in those days, the patients who qualified for immunotherapy were generally the fitter patients anyway. So there might be some confounding over there. But if you average that 7 and 2 survival benefit, you come up to about 3 months. Most importantly, there was no added systemic toxicities, which is very, very important. And these are what the graphs look like. So you have a benefit from about 9.9 months to 13.2 months. But if you break that up into your immunotherapy on the left, you have a greater benefit compared to the chemotherapy on the right. So given the success of the LUNA-1 phase 3 trial, the question becomes, how far up the treatment algorithm can you improve or can you see the benefit? In the same way that Trident did it for EF14, LUNA-2 is trying to do it for LUNA-1. So the first line of standard of care has changed. In the past, it used to be chemotherapy doublet. It's now a combination of chemotherapy, immunotherapy. So what we're trying to do is, in the chemotherapy, immunotherapy, if you add the Optune treatment at the beginning and then you move on to the maintenance with Optune, does that benefit you compared to not having that at all? So we were hoping to be the first UK centre to recruit to the LUNA-2 trial, which has started recruiting. We passed all the regulatory steps at the end of last year. We were selected to be the first site to recruit. Unfortunately, the study was withdrawn from its entirety in the UK a few months ago, and it was commercial reasons. I won't go into the politics of that. Needless to say, it was hugely disappointing for us, for our patients, and we're trying to sort of work behind the scenes to see if we can actually change that. However, we are pushing ahead with mesothelioma treatment. So the LUNA-1 and 2 was all to do with non-small cell cancer. When it comes to mesothelioma treatment, the evidence is actually not as strong. So rather than a phase 3 trial, the STELLA trial was a phase 2, which meant it was a single arm trial with no comparator. It was a smaller group of people of about 80. And in mesothelioma, whereas chemotherapy, immunotherapy was the first line treatment, the question was, adding Optune, does that benefit? So we know in mesothelioma that average survival without chemotherapy is about 9 months. And if you add chemotherapy, which was the standard of care, you increase that to 12 months. And if you add Optune, you extended the median overall survival from 9 months to about 18 months. Okay, so that was a phase 2 80 patient trial. Now, this has not been translated to NHS, but it has been adopted in the USA and in Hong Kong. The reasons NHS has not adapted it is because it was a phase 2, so there's no comparator arm. Phase 3 data is needed. And in the last few years, since STELLA trial published, the standard of care for mesothelioma has also changed. It used to be chemotherapy. It's now immunotherapy doublet, which gives you an equivalent overall survival of about 18 months. However, there is still a role for it in the second line setting after people progress on immunotherapy and then they go into chemotherapy. So we actually have the first patient in the UK who started treatment on Optune for mesothelioma, and he's had mesothelioma treatment, he had Optune treatment with 6 cycles of chemotherapy, and I'm waiting for his scan result, which will hopefully be reported in the next couple of weeks or so. So my last slide is essentially lung cancer is the most deadly cancer in the UK and globally. The most common is stage 4 non-small cell lung cancer, and I've explained why we need new treatments for that. The LUNA-1 trial met its endpoint and has set up the LUNA-2 trial, which is trying to drag that benefit up into the earlier setting. As of October of this year, Optune for non-small cell lung cancer actually been FDA approved in the USA, so it's now forming part of their standard of care. And mesothelioma is used in the USA and Hong Kong, but we need to just sort of campaign more for its use in the UK. And we do have the first patient at Charing Cross who's on that treatment. And you guys are obviously well aware of our study days here and our clinics, etc. So that's it. If there's any questions, I'll try and answer them. We'll start with questions in the room. So any questions about Optune in lung cancer, mesothelioma from the room? Yes, Ollie, yes.
Thanks for a really interesting talk. I was just very interested about, because of the way the arrays are placed sort of on the thoracic cavity, you have, front, back, and potentially from the sides as well. When you look at the imaging from patients that go on to have progression, do you see any differences in the shape of those tumours as you progress? Because I guess from the preclinical work, you might predict that, tumours that are less able to grow in those directions, but are more able to grow sort of, up and down because of you've got range orthogonally from the front, back, and sides, but not necessarily from the top.
So
Bottom.
it's a good question. I think that,
Can you
so,
recap the
oh
question?
yes, so the question is, if I'm reading it correctly, does the application of Optune onto the thorax modify the expansion of lung tumors?
Yeah, and the direction.
And so does it affect the differential growth of lung cancers? Number one, in my experience, I've not had that many patients to have noticed, and I don't think that evidence exists. Number two, in the same way that we use MRI scans to dictate the positioning of arrays for GBM patients, we are using CT scans to dictate the positioning of the arrays for thoracic tumors, whether they're front and front, back, front and side. How the idea is that by applying the arrays in that sort of orthogonal manner, you're going to get the biggest coverage. And so the idea is that you will not necessarily uniformly, but in terms of dimensions, you will affect or hit the cancer as equally as possible. But in terms of tumor density, etc., and how that affects growth, no, I don't have an answer to that, unfortunately. It's a good question, Olive. Anup, yeah.
So obviously in lung, different than from brain, you've got large air spaces. So it's not a uniform density that we've got in the tissue.
Yeah.
So does that modify the way that we apply the arrays? In terms of the voltage or anything energy that goes through from different positions.
Yes.
You have to modulate that will make a difference.
So Anup's question is, unlike the brain, which is relatively homogeneous in its density, the lung is filled with air-filled cavities, which affects its density. And does that impact on the electrical conduction of Optune? And I don't know if you remember, Anup, this is the question I asked Olu at our last meeting, where I said, does the air cavity affect the conduction of electricity? And there was no evidence that it did. So in the absence of evidence that an air cavity would affect your conduction, it's until the further evidence, it's as homogeneous as the brain. It might be less dense, but it's equally less dense as the density of the brain, if that makes sense. Yeah. Dr. Salim? Yes, so the frequency is 150 compared to 200. No, I don't know. So Dr. Salim's question was, he's astutely pointed out that the frequency of the Optune device differs in both lung and in GBMs. Now, I'm not entirely sure how that came about, but it is the case that slightly different frequencies are used. Now, we know that there's a relationship between frequency, tissue density, and heating. So it could be that the lower frequency in the lungs is less likely to cause upheating, but how that impacts on its success, for example, if you were to turn up the frequency, that simply hasn't been looked at yet.
Brilliant. I might allow for one question in the remote audience. Otherwise, we will move over to the panel discussion, which Dr. Mohammed will also be joining. So in order for me to set that up, I'm going to say thank you to Dr. Mohammed for such an interesting talk. And I'm going to set up the next session.
Thank you, Waleed.
So, do not go on your lunch breaks yet, because we've got a really interesting panel discussion.